So why do we memorize that drugs such as erythromycin and the class 3 antiarrhythmics predispose patients to torsades? Probably because you, just like I, never had enough time to understand that both of these drug classes inhibit potassium channels that are responsible for a repolarization phase. This is the same reason that class 1A antiarrhythmics can also lead to torsade. They prolong the QT interval because they also block these potassium channels. So as you can see here, this is your potassium channel responsible for the efflux of potassium out of the cell to repolarize. Drugs such as erythromycin are class 3 antiarrhythmics, and class 1A antiarrhythmics will sit and block this domain, preventing this from flowing out, causing a decrease in our IKR current. How does low magnesium levels predispose you to torsade? Number one, you need to know that most of the time in real patients, and also in your vignettes, that if you see low magnesium, you're most definitely going to have other electrolyte abnormalities, such as low potassium. But why? And how does this contribute to the etiology or pathophysiology of torsades? Well, the sodium-potassium ATPase pump requires magnesium for its function. Without magnesium, it's not going to work. Remember, the sodium-potassium ATPase functions to restore the normal intracellular high level of potassium using the extracellular levels of potassium to pump it back in and restore it. What do you think will happen if you have low magnesium and you can't use it as a cofactor to restore the normal concentration of potassium in the cell? Well, you're going to lose your ability to use magnesium as a cofactor, and therefore you won't be able to pump this potassium back in. You'll have low levels of intracellular potassium. You'll have high levels of extracellular potassium. So you will not have enough potassium in the intracellular environment for sufficient potassium efflux to contribute to the normal phase 3 repolarization that is key to preventing torsades. The same situation occurs if someone has been hypokalemic for a while. Eventually, you're going to pump out all of your intracellular calcium to try to maintain normal extracellular or serum calcium level, or normal serum potassium levels. Eventually, they'll be depleted, and you won't have a normal intracellular potassium. So guess what will happen to the flow of potassium across the potassium channels that are responsible for the phase 3 repolarization? It will take much longer to complete the phase 3 because there will be less potassium ions available to produce it. So that is the decrease in the potassium efflux due to a loss of this magnesium. This is setting us up for torsade deployment because we have areas that are still depolarized or about to start repolarizing while other areas of the myocardium have regained excitability, as we just saw on the last slide. These heterogeneous changes in action potential synchronization among the ventricles can produce multiple areas where the myocytes are depolarizing at completely different times from one another. When you get areas of depolarization that are completely out of sync from each other, then you start to get a polymorphic, just like this, wave. And this should make a lot of sense because there's many or poly areas of different depolarization rates among the ventricles due to this abnormal synchronization. So, many different ways of depolarization, poly areas, many areas, will show up as polymorphic waves on your ECG. This should really make a lot of sense to you because that is the basis of torsade points. We have created areas where there's many different areas of depolarization at different times. And this creates the illusion that you are twisting around the baseline of what you would expect. And that is what torsade point means. It is twisting of the points in French. And the reason that it looks like this is just because we have multiple areas of depolarizations. So this is a depolarization, this is depolarization, this is a repolarization, and they're all occurring at different times. And that gives you the illusion that there's no regular baseline, except that you're just twisting around it. Torsade de points is a polymorphic, so many different waves, ventricular tachycardia. It is named so due to the appearance that the points are twisting around the expected isoelectric line of the ECG. Magnesium sulfate, editor, please go back. Magnesium sulfate is a treatment for torsade because it can slow down the calcium influx across the myocyte membrane as well as limit the efflux from the sarcoplasmic reticulum. That is an important part of myocardial-site depolarization. The reason that you give magnesium sulfate is that it can directly sit inside the calcium transmembrane channel and block further entrance of calcium. And that is how magnesium can stabilize that myocardium. What is another condition that is treated with magnesium sulfate? Let me just kind of switch gears up and toss something in for you, a little vignette. So we have a 27-year-old African American female at 22 weeks gestation, presents with severe headache, lightheadedness, papilledema, proteinuria, and generalized convulsions. So again, 27-year-old African American female, 22 weeks gestational age, presents with headache, lightheadedness, papilledema, proteinuria, which is more than 3.5 grams per day in the urine, which is a lot, and seizures. In this situation, we should all be thinking about eclampsia. She's past 20 weeks gestational age, she's having seizures, she's having protein in the urine, she's having extremely high levels of blood pressure, delivered by the papilledema and the headache. So let's go back and think about this. The underdevelopment of the placental vasculature causes an underperfusion and relative hypoxia of the fetus. So your vasculature in the placenta sucks. And this is the pathophysiology of eclampsia, which you would treat with magnesium sulfate. So eclampsia. The vasculature in the placenta sucks. You have low oxygen delivery to the fetus. The fetus says, hey, what's going on? I need some oxygen. I'm trying to grow. And that triggers the release of angiogenic and vasoconstrictive factors into the maternal circulation. So angiogenic and vasoconstrictive substances. It wants to make more blood vessels and clamp down on other vessels in the maternal circulation so more blood can reach the placenta. And that will really mess with the mom's circulation. The etiology of the seizures is not completely clear yet, but you can stabilize the neurons with the administration of magnesium sulfate. Just how magnesium sulfate sat in the channel in our myocardium, it will do the exact same for neurons. And it will block further influx of calcium, which is neurotoxic if you accumulate high level of calcium in neurons. The only cure that is permanent for eclampsia is to get that placenta out of there because it was acting all crazy and making these angiogenic and vasoconstrictive factors. So in summary, if someone says torsade de pointe, someone says eclampsia, you scream out magnesium sulfate. Alright, so now we have a flash quiz upon us. We haven't necessarily reviewed this yet, but this is a good flash quiz because it'll get us thinking about something that we're going to talk about in a couple of slides, and it gives us a break from torsades. So, let's read the question. What is the characteristic electrocardiogram finding of first-degree atrioventricular block? You guys know this all day. That is a prolonged PR interval of over 200 milliseconds with no lengthening of the interval and no dropped beats. So remember back to when you initially reviewed this the first time. First-degree block is characterized by some sort of deficiency in the atrioventricular node so that it cannot conduct properly. This will be represented on your ECG by a prolonged PR interval. So again, our PR interval will be prolonged because of some intrinsic deficiency of the AV node. It is usually due to the depression of conductance of the cells within the AV node by something like hyperactive vagal tone or someone on a beta blocker. They will not drop beats because the cells are fine structurally. All that's going on is that we just have some sort of intrinsic inhibition. If we drop a beat, then that means that the cells were gradually losing their ability to restore normal ion concentrations and therefore will not be able to perform future depolarizations. Dropping beats is bad, and you do not see drop beats in first-degree AV block. In the case of more severe AV nodal dysfunction, you would just not conduct beats at all. Alright, great. Now let's talk a little bit more about torsades. We took a break there with that flash quiz, but now let's get our mind back to it. So we discussed that the potassium current responsible for the timely repolarization of cardiomyocytes can be blocked by certain drugs. Remember, the phase 3 efflux of potassium dominates that repolarization phase. Drugs that can block those potassium channels can actually cause prolongation of our QT and lead to torsade. But now let's talk about how people can be born with specific gene mutations that can cause them to produce abnormal components of these potassium channels, which can predispose them to developing some conduction abnormalities, which is referred to as congenital long QT syndromes. This is a slide that includes causes of torsades. We will focus on the left acquired column. Both Romano-Ward and Jervell-Lange-Nielsen syndrome are congenital long QT syndromes associated with mutations in the genes responsible for coding the structural components of potassium channels, and also for the proteins that are going to insert them into membranes of conductive cells. So again, let's repeat that. These are syndromes associated with mutations in the genes responsible for coding the structural components of potassium channels, or mutations in the genes coding for proteins that insert them into membranes. So this is a membrane, and these are potassium channels. What is the difference between Jervell and Lange-Nielsen versus Romano-Ward syndrome? Romano-Ward syndrome is autosomal dominant, while Jervell and Lange-Nielsen is autosomal recessive. Why does Jervell and Lange-Nielsen have sensory neural deafness in addition to the predisposition for a long QT? Well, there are some genes that are defective in this condition, which I remember by the fact that there are more names in this disease. So more names in the disease, there are more genes affected compared to Romano-Ward. So the potassium channels responsible for the conductivity of hair cells in the inner ear are completely dysfunctional in Jervell-Lange-Nielsen syndrome. So that is why you have sensory neural deafness. How do I remember that individuals with Jervell and Lange-Nielsen syndrome suffer from sensory neural deafness? Well, it takes much longer to hear and say that name, and therefore I associate it with something that's associated with the ear. So remember, both of these are defects in potassium channels due to mutations in the genes coding for the structural components of the potassium channels, or the proteins that are supposed to insert them into the membranes of the cells that the potassium channels are supposed to be in. Romano-Ward is autosomal dominant. Jervell-Lange-Nielsen is autosomal recessive. Jervell-Lange-Nielsen also has a component of deafness.